Usually when we talk about a medical diagnosis, there's this underlying expectation of precision.
Right, like it's a math equation or something.
Yeah, exactly. It's like engineering. I mean, you break your arm, the x-ray shows that jagged white line, and the doctor just points at the screen and says, well, there it is. Broken.
It's comforting to have that binary reality. We naturally gravitate toward things that can be seen, categorized, and, immediately fixed.
But then you step outside of simple fractures and into systems like, say, neurodevelopment or chronic pain, and suddenly that x-ray machine is kind of useless.
Oh, absolutely. The picture gets fuzzy really fast.
Right. And we find ourselves looking at a diagnostic landscape that is honestly incredibly murky. And that exact same feeling of murky, complicated engineering applies to what we are exploring today.
It really does. It's a fascinating area.
We're looking at a stack of really diverse medical sources today. We've got urogynecology studies from Indonesia and Taiwan, some clinical trial data on diagnostic tools, historical reviews of pelvic floor anatomy, and some incredibly cutting-edge biomechanical critiques.
Yeah, the physics critiques are particularly mind-bending, I have to say.
They really are. So our mission for this deep dive is to answer a very specific, highly mechanical question. What is urethral hypermobility, and how does it physically cause stress urinary incontinence?
And while that sounds like a hyper-specialized medical issue, at its core, this is just a pure problem of physics and structural engineering happening inside the human body.
Exactly. So whether you, our listener, have personally experienced the dreaded leak when you laugh or cough or sneeze, or you're just insanely curious about the hidden engineering of the female body, this deep dive is going to fundamentally change how you view something as simple as a sneeze.
I guarantee you'll never think about a cough the same way again.
Seriously. We are going to look at the physics of how the body stays dry under pressure and what physically breaks down when it doesn't. Okay, let's unpack this. What exactly is moving and why?
Well, let's start with a baseline.
Yeah, let's do that. When we talk about hypermobility in the context of the bladder and the urethra, what is actually happening in there?
So, at a fundamental level, hypermobility just means there is too much movement. Normally, your bladder and your urethra, which is just the tube that carries urine out of the body, they sit securely anchored in the pelvis.
Like they're strapped down.
Right. They are held in place by this intricate, interwoven network of muscles, ligaments, and connective tissues. Urethral hypermobility happens when that support system basically degrades.
Got it.
The moment intra-abdominal pressure increases, the urethra and the bladder neck physically descend, or they, rotate abnormally downward from their normal resting position.
And when we talk about intra-abdominal pressure increasing, we aren't talking about extreme sports here. We're talking about everyday exertion, right?
Completely.
Like laughing, coughing, bending over to lift a heavy box, sneezing.
Yeah, think about what a sneeze actually is mechanically. It isn't just air gently leaving your lungs. It creates this massive, violent pressure spike throughout your entire abdominal cavity.
It's basically a mini explosion inside your torso.
Exactly. And when the structural support beneath the bladder is compromised, the urethra just drops down under the sheer force of that pressure.
Which makes sense. And the sources outline several key risk factors that cause this support to fail in the first place, right?
They do. Vaginal delivery is a major one,
Right.
as it can severely stretch and even tear the levator ani muscle and all the associated pelvic nerves in that area.
I noticed obesity was mentioned heavily in the studies as well. There's a major study out of Indonesia in our stack highlighting that a body mass index over 24 or 25 is a significant trigger.
Yeah, that BMI threshold is a big factor.
I assume that acts like a constant heavy weight just resting on that pelvic support system all day.
It acts exactly like a continuous mechanical load. Chronically elevated abdominal pressure constantly strains those ligaments until they just sort of give way.
That makes total sense, like stretching a rubber band until it loses its snap.
Right. And then there's the biological shift of menopause. Estrogen plays a really critical role in maintaining the integrity and the balance of connective tissue and collagen throughout the pelvic floor.
So when estrogen drops, the tissue changes.
Dramatically. When estrogen levels plummet during menopause, those tissues literally lose their elasticity and structural strength. They thin out, which allows that downward rotation of the bladder neck to occur much more easily.
Okay, I'm trying to visualize how that downward movement actually translates into a leak, though. I was reading one of the older studies in our stack, and it made this fascinating point about pressure.
The pressure transmission stuff.
Yeah. Normally, a cough squeezes everything in that area equally, right? Like, squeezing a water balloon in your fist, the water has nowhere to go because the pressure is uniform all the way around.
That is a great analogy. That concept is known in the medical literature as the pressure transmission theory, which was originally proposed by a researcher named Inherning.
Pinherning, right.
When the anatomy is in its proper place, the pressure from a cough hits both the bladder and the proximal urethra, the top part of the tube, equally. That equal external pressure keeps the tube squeezed perfectly shut.
But if the pelvic support is weak, the bladder neck descends out of that high pressure zone.
Exactly. It drops right out of the safe zone.
Meaning the pressure only hits the bladder, so it squeezes the balloon, but the nozzle is left totally unguarded.
You nailed it. The cough turns the bladder into a pressurized vessel, violently forcing urine into a urethra that is no longer receiving that external closing pressure to fight back.
Wow.
And this works in tandem with another foundational concept called the hammock theory, developed by Delancey.
Okay, the hammock theory. How does that fit in?
Well, in a healthy system, the urethra rests on a supportive hammock made of endopelvic fascia and the anterior vaginal wall. When you cough, the abdominal pressure pushes the urethra down against this firm hammock.
And the hammock pushes back.
Right. The hammock pushes back, and the tube is compressed shut against it.
So think of a garden hose lying on a concrete driveway. If you step on the hose, the water stops immediately because the concrete gives it a hard backing.
Yes, perfect visual.
But if that hose is suspended over a loose trampoline, stepping on it just pushes the hose down deep into the mesh and the water keeps flowing. The firm backing just isn't there.
If we connect this to the bigger picture, that missing concrete driveway is the core culprit for the vast majority of patients.
Just how many are we talking about?
Roughly 85% of women experiencing stress urinary incontinence leak primarily because of this exact mechanism: urethral hypermobility.
Wow, 85%. Here's where it gets really interesting, though. We've established this hammock, this trampoline concept, but as I read through the advanced biomechanics in the stack, treating this just like a static shelf holding up a box seems way too simplistic.
It is too simplistic. You're definitely onto something there.
In fact, hang on, I'm genuinely struggling to buy the traditional models. If my pelvic floor is just a tight membrane holding up my internal organs, why doesn't it just completely rupture when I sneeze?
Right, because a sneeze is a huge event.
A sneeze is violent. A static shelf wouldn't survive that over an 80-year lifespan. It would just break.
Your skepticism is entirely justified, and it is exactly what drove the newer physics critiques we are looking at.
Okay, so I'm not crazy.
Not at all. The traditional model, which is known as the integral theory by Petros and Olmsted, viewed continence strictly through the tension of connective tissue. In their model, the ligaments are like the springs on a trampoline, and the vaginal wall is the membrane.
So if the springs are loose, it fails.
Right, if the springs are loose, the pelvic muscles cannot generate enough tension to stretch the membrane tight enough to close the urethra.
But that still relies on a static tension. It just doesn't account for the sheer violence of a cough.
And what's fascinating here is how applying classical physics completely redefines our understanding of human biology. We have a radical critique in our stack by a researcher named Shen.
Shen, yes. This part blew my mind.
Shen points out that a cough is absolutely not a static load. It is a massive impact force. It spikes to like 100 or 150 centimeters of water pressure in a matter of milliseconds.
Which is an insane amount of pressure that fast.
It is. You cannot resist a sudden impact force like that with a static shelf. It would shatter instantly.
So how does the body actually survive it without just blowing out every time we cough?
Shen proposes that physiological continence is actually governed by the physics of an elastic collision.
Elastic collision.
Yes. When you cough, a specific muscle, the levator plate, actively contracts, tethering the bladder neck to the pubic bone. They refer to this as the A-lock, which creates a zero-radius closure of the urethra.
Okay, so it locks it down tight.
Exactly.
Ah.
And as the massive kinetic energy of the cough pushes down, the pelvic floor doesn't just block it like a wall. It absorbs that energy by stretching, storing the kinetic force as elastic potential energy.
Like drawing back a heavy bowstring or stretching a thick rubber band. The energy isn't gone, it's just being temporarily held in the stretch.
Exactly. The moment the cough passes, that stored potential energy causes the tissue to snap back, completely recovering its original shape. It is a fully reversible elastic collision.
That is just brilliant engineering.
It really is. Natural selection optimized this entire system based on something called the principle of least action. Over a lifetime of storing and releasing urine, this elastic mechanism costs the body almost zero net energy.
Because it recycles the force.
Yes, the violent energy of the impact itself is literally recycled to restore the organ to its resting state.
That is mind-blowing. It's not a physical wall, it's a dynamic energy recycling shock absorber.
A perfect shock absorber, yeah.
But if we accept that the urethra handles these extreme impact forces dynamically, what happens to the physical shape of the urethra when those shock absorbers completely blow out?
But things go wrong very quickly.
Right, because the urethra doesn't just float there in a void, it drops. And that has to create a whole new mechanical nightmare, doesn't it?
It creates a severe structural breakdown. This is detailed in the sources as the urethral hanging theory, which was proposed by Bergstrom.
Urethral hanging theory, that sounds painful.
It's definitely destructive. When the posterior ligaments are defective, that dynamic shock absorber fails. The proximal urethra, the top part closest to the bladder, descends forcefully during a cough.
But it doesn't fall forever, right?
No, it doesn't fall freely forever. It gets tethered. It hits the end of its anatomical leash and ends up hanging on a bladder neck that is less mobile.
So it basically falls, hits the end of the line, and just hangs there, bearing all that internal abdominal pressure.
Exactly. And this hanging action generates intense physical pulling forces, specifically shearing and distending forces.
So it's being ripped at.
Yeah, the sheer weight and the angle of the pressure actually pull the top of the urethra open into a funnel shape. The medical term for this is forced funneling. The anatomy is literally being pulled apart by the awkward angle of its own descent.
Wow, it sounds like pulling a taut rope over the sharp edge of a cliff.
That's a really good way to picture it.
The extreme angle and the heavy weight hanging off the edge literally force the top of the rope to fray or open up. It's a structural shearing.
That visual perfectly captures the mechanical strain on the tissue. And understanding this shearing force is crucial for differentiating hypermobility from another condition called intrinsic sphincter deficiency, or ISD.
Oh, I saw ISD mentioned as something that often coexists with hypermobility. But mechanically, they are totally different beasts, right?
Completely different. ISD is when the sphincter muscle itself is inherently weak, what the sources sometimes refer to as a lead pipe urethra.
A lead pipe, meaning it's just rigid and open.
Exactly. With ISD, the urethra is often open even at complete rest. The internal seal is just broken on a muscular level.
Oh, okay.
But with urethral hypermobility, the urethra is usually closed perfectly well at rest. It only gets pulled or pushed open during the stress event when that hanging and force funneling physically pries it apart.
So what does this all mean for someone seeking treatment? It tells us that if a patient is leaking due to hypermobility, just trying to bulk up or medically treat the sphincter muscle alone is just a fool's errand.
It won't solve the core issue, no.
Because you haven't addressed the underlying structural drop. The cliff edge is still there, pulling the rope apart every time they sneeze. It's a cascading mechanical failure.
You have to fix the support system to stop the descent and prevent the hanging. Otherwise, the basic physics of the abdominal pressure will defeat whatever muscle level fix you attempt.
Okay, so we have mapped out this incredible, extreme biomechanical event happening in a fraction of a second inside the human body. But I want to pivot to the practical reality of this.
Sure, let's look at the clinical side.
How do doctors actually see and measure this tiny, rapid descent in a clinical setting? I mean, how do we prove the hypermobility is happening before someone goes into surgery?
Well, this brings us to a rather archaic and uncomfortable chapter in urogynecology. For decades, the historical gold standard for measuring urethral mobility has been the Q-tip test.
At the Q-tip test, I read the descriptions of this in the stack, and it honestly sounds medieval.
It is remarkably rudimentary, I won't lie. A sterile, lubricated cotton swab is inserted directly into the patient's urethra and pushed right up to the bladder neck.
Ouch. Just ouch.
Yeah. Then the patient is asked to cough or bear down intensely to perform a Valsalva maneuver. The clinician simply watches the wooden end of the swab sticking out of the body.
Like watching a joystick move.
Exactly like a joystick.
Yeah.
If the internal bladder neck drops, the external stick pivots upwards. If it rotates more than 30 degrees from the horizontal plane, it indicates significant urethral hypermobility.
It's basically a simple lever mechanism to visualize the internal drop.
That's all it is.
But the major glaring issue, which is thoroughly documented in our sources, is the sheer discomfort. There's a study here from Indonesia looking at women with stress urinary incontinence, and it found that nearly a fifth of the patients, around 17%, reported such severe discomfort and pain during the Q-tip test that they literally required medication to manage their symptoms afterwards.
And the pain isn't just a matter of patient comfort. It actively sabotages the clinical data.
Wait, how so?
Think about it.
Yeah.
If a patient is anticipating sharp pain in a highly sensitive area, they are not going to push or cough as hard as they naturally would.
Oh, they flinch, of course.
They flinch. This leads to suboptimal straining, which results in false negatives. The test tells the doctor the patient's mobility is fine, but only because it hurt too much for the patient to demonstrate the actual problem.
Which naturally led researchers to look for alternatives. There's a randomized crossover trial in our stack that tested a vaginal swab alternative.
Yes, a much better approach.
Right. Instead of putting the rigid swab into the highly sensitive urethra, they placed it in the vagina to measure the rotation of the anterior vaginal wall, which is structurally glued to the urethra anyway.
And the clinical results were identical. The trial proved the vaginal swab was just as accurate in diagnosing hypermobility as the urethral Q-tip test.
But the patient experience had to be better, right?
Staggeringly better. On a pain scale of 0 to 10, the median pain score for the vaginal swab was a 0.
A 0.
Yep. For the urethral swab, it was a 3. Unsurprisingly, the vast majority of women, 68%, preferred the vaginal approach, and absolutely 0 preferred the traditional urethral Q-tip.
0%. I mean, that is as definitive a rejection as you can get in a clinical trial.
You rarely see a literal 0 in patient preference data.
But beyond cotton swabs, we also have modern, high-tech options in the stack. Pelvic floor ultrasound. This is entirely non-invasive. You just use an ultrasound probe externally to literally watch the bladder neck move on a screen in real time.
It's fantastic technology.
Yeah.
It measures the bladder neck descent in exact millimeters.
So no sticks required at all.
None. Ultrasound provides incredibly detailed dynamic imaging without the trauma of the Q-tip. It allows clinicians to measure specific geometry, like the retrovesical angle, which is essentially just the physical angle between the base of the bladder and the top of the urethra.
Got it.
When the bladder neck drops, that geometric angle changes drastically on the screen.
But looking at the data, the medical community hasn't totally figured out what to do with this imaging yet, right?
There is still a lot of debate, yes.
The Indonesian study noted that while the ultrasound had incredibly high sensitivity, like over 92%, meaning it rarely misses hypermobility if it's there, it had very low specificity, sitting around 33%.
That low specificity is a real clinical hurdle.
Mm-hmm.
It means the ultrasound is so sensitive that it might be picking up natural, harmless movement that isn't actually causing the incontinence.
So it flags everything as a problem.
Pretty much. A study out of Taiwan suggested a cutoff of about 13.3 millimeters of descent to diagnose hypermobility. But the Indonesian study used a cutoff closer to 21 millimeters.
That is a huge difference in measurement.
It is. The medical field is still intensely debating exactly how many millimeters of drop constitutes a failure of the system.
So on behalf of our listener, I have to ask a very pointed question here. If the Q-tip test is notoriously painful, it causes false negatives because patients understandably flinch, and we have non-invasive ultrasound that can literally see the bladder neck descend in real time. Why on earth is a rigid cotton swab still part of the conversation today?
That is the big question, and it raises an important point about how medical practice actually evolves or struggles to evolve in the real world. You have to consider systemic friction and resource allocation.
Meaning the reality of hospitals versus lab theories.
Exactly. Pelvic floor ultrasounds require highly specialized, expensive equipment. They require complex software to calculate things like that retrovesical angle. And crucially, they require a sonographer or physician with advanced training to interpret dynamic pelvic floor movement.
Whereas a cotton swab is just lying in a jar in literally every clinic on Earth.
A cotton swab is virtually free. It is immediate. A primary care doctor in a rural clinic can perform it in 2 minutes.
Right.
Yes, it is rudimentary, and yes, it is deeply uncomfortable, but for decades, it was the only objective metric surgeons had to justify operating. The transition from a cheap, universally available physical test to a specialized, expensive imaging modality takes a massive amount of time.
Especially in developing healthcare systems or general practice clinics.
Exactly. It's a slow-turning ship.
It's the friction between the ideal physics we understand on paper and the harsh realities of global healthcare systems.
Well said.
So, to summarize our mission today, we set out to understand what urethral hypermobility is and how it physically causes stress urinary incontinence.
And we covered a lot of ground.
We really did. And what we've uncovered is that it is far from a simple muscle weakness. It is a complex, dynamic breakdown of pressure transmission. It's a failure of the body's natural shock absorbers, turning a brilliant energy recycling elastic collision into a structural shearing event where the urethra hangs, stretches, and funnels open under the massive impact of a sneeze.
It really highlights how incredible the unbroken system is.
It does. And for you, the listener, whether you are dealing with this yourself or you're just fascinated by the biology, I think understanding these mechanics is deeply empowering. It takes a condition that society often cloaks in embarrassment and it turns it into a solvable, logical physics puzzle. It is an engineering problem, and engineering problems have solutions.
They do have solutions, but I want to leave you with a final, somewhat provocative thought pulled directly from that physics critique in the Keough source.
But please do.
We established earlier that physiological continence is truly an elastic collision, a dynamic system that requires 100% deformation recovery to function properly over a lifetime. It stretches and it snaps back.
Right. It has to bounce back perfectly.
So if that is the fundamental physics of the human body, what happens when surgeons treat hypermobility by implanting a permanent non-stretchable polypropylene mid-urethral sling?
Oh, wow. The mesh slings.
Exactly. This synthetic mesh has been the surgical gold standard for decades. But by introducing a rigid, inelastic foreign body into a purely elastic system, classical physics dictates that the surrounding tissue will inevitably suffer fatigue and creep over time.
Because the mesh won't stretch with the impact of the cough, so the soft tissue takes all the kinetic damage instead.
Yes. The tissue absorbs the trauma the mesh refuses to take. Therefore, the long-term complications we see with mesh slings, things like chronic pelvic pain or the sudden development of new overactive bladder symptoms years after surgery, might not just be random surgical errors or bad luck.
They're basically guaranteed by the physics.
According to this physics model, they are unavoidable physical inevitabilities of putting a static element in dynamic system. It leaves us to seriously ponder whether the future of treating hypermobility requires abandoning permanent synthetic implants altogether in favor of pure physiological reconstruction using the body's own elastic tissues.
Wow. So we are right back to where we started. You look for the clean, engineered fix, the simple mesh sling holding up the plumbing like a cast on a broken bone. But the reality of the human body with its elastic collisions and dynamic shock absorbers makes that landscape incredibly murky. The quick fix might actually break the physics long term.
It's a lot to think about.
It really is. Thank you for taking this deep dive with us. Keep questioning the physics of your own world, and we'll see you on the next one.